Hi, I'm Michael. This is for the paper Contemporary Intensive Paramedicine. We'll be demonstrating the treatment and rationale behind someone with a Brady dysrhythmia. Does everyone see my patient? What does he look like? Hello, sir, can you hear me?
Yeah. Hello. Who are you?
Squeeze my hand for me. Good response. Sorry, who are you?
My name's Doris.
Hi, Doris. My name is Michael. Who's this?
This is Clive.
Clive. How long has Clive been like this for?
A couple of hours. He's not been well. He's had a bit of a turn, I think.
Very slow heart rate. Does he normally look this grey and diaphoretic?
No, he looks awful.
Does he normally look awful?
No.
Okay. So tell me what's happened today.
He's normally really good. His name's Clive.
Clive?
And he's normally good. He's fit. He gets around on his own.
Yep.
Goes for walks every day. Me and him go walking.
Have you been walking today?
Yep.
Obviously earlier today.
Yeah. No, we did. Went for a normal walk. He's but he was feeling very, very tired, very washed out.
Sure.
He doesn't have a nap during the day, but he needed to have one today. He came back home, just went straight to bed. He's feeling a bit dizzy.
Okay. Was he complaining of anything else?
Bit of pain in his chest, I think he was saying.
Okay. Well, do you know if that pain was going anywhere else or was just in his chest?
He just said his chest.
Okay. Has he been a bit more short of breath?
Yeah, he's been a bit huffy and puffy.
Yeah. Any coughs, colds, or anything like that recently?
No.
Okay. Any other complaints?
No.
No.
He complains about everything.
Yeah.
Yeah.
He's going to do his blood pressure for us. Any regular medication?
Yeah, he don't. Just vitamins, I think.
Just the vitamins?
Yeah.
Okay. Cool. And so, Dolores,
Yeah.
when was the last time you went and saw his doctor?
He's so good normally. He doesn't have to see the doctor very much.
Okay. And so when was the last time you actually saw the doctor? I'm just putting a few more sticky dots on your chest.
I honestly couldn't tell. It wouldn't have been in the last 12 months.
Okay. And like you said, no regular medication.
No.
Any heart problems?
No.
No. Any family history of heart problems?
Oh, I don't know. I don't think so.
Yeah, I guess. Do you not like his family?
No.
Okay. All right. Just doing a 12 beat, Greg. Just stay nice and still for me.
Clive.
Clive. How old is Clive? Gregory.
He's getting on 65, I think now.
65. All right.
He's getting the pension.
Yeah. Are you a bit older? Are you?
Yeah.
Yeah.
Cougar. Is this heart okay?
It's a bit slow at the moment, okay, and his blood pressure's quite low as well. So we're a little bit concerned. I'll just finish this and have a quick look at it. Straighten that off. Right, come on down and we'll look at this 12 lead. Okay, so what we can see here on the 12 lead is we have the 6-second strip down here. We can see that it's a narrow complex and it's also bradycardic. What we also notice is our P waves not corresponding to every QRS. And so what we can see is we can see a complete disassociation between the atria and the ventricles. This is represented between the regularity of the P waves and the regularity or the uniformity of the QRS complexes. This indicates that the impulse is becoming blocked and an accessory pathway has had to be made in order for those ventricles to contract. We can confirm that the patient is in a 3rd degree heart block or a complete heart block. Okay, so far we've gathered that Clive here has a heart rate of 32, that is regular. He has a blood pressure of 60 on palpation. He's saturating poorly at 92%. He has a respirator of 28, a temp of 35.6, and a BGL of 6.2. Based on those numbers and based on the patient's GCS also being altered at 13, losing one for voice and one for eye opening, he is deemed to be severely compromised and at this stage is a status 1 patient. Okay, so at this stage, we'll just silence that. At this stage, we'll get Dolores to come down and hold old Clive's hand. I'm also going to put Clive on some oxygen, just some nasos at this stage. We'll get Dolores to come down and just hold Clive's hand, and I'm just going to pop some oxygen on him. Just some nasos at this stage, and we'll go at 4 litres. Turn that on, and then my priority will be gaining large bore IV access in the central site, something like as ACF. At this stage, I've already gained large bore IV access. We've also set up our resuscitation gear with OPA or similar measured, as well as a bag valve mask out and ready just in case this turns into an arrest. For our current CPGs, we have a pacing checklist, which is always good to pull out and refer to as we go. So I've got that here on my iPhone. What we've done is we've placed the pads here at the anterior posterior, which is the desired site for when you are doing pacing. We've also selected the R wave with the highest, the limb lead with the highest R wave, which in this case has been lead 2. Cool. And we've minimised artifact by ensuring that Dolores isn't touching Clive anymore, which is good. And then what we're going to do is we're going to place it in pacing mode. And for these ones here, we don't need to choose the mode, so we've got between demand and fixed. It automatically comes up as demand. We have the you in here.
I'm coming in.
We have the pacer rate set at 90 and the pacer output, which is normally set quite low. So in the first instance, what we want to do is ensure that it is set at 70 to start off with, and we then, for this, start pacing before then increasing the pacer output. As we do this, we want to confirm that there is a detection symbol above every QRS, which we have at 80. And then go 10 milliamps above and press enter. Cool, so we're currently pacing this patient about 70 beats per minute. What I would then want to do is ensure that we're getting, from the electrical output, we're getting mechanical in the form of palpable pulse, either at the brachial or the radial. If we haven't increased that, what we then want to do is increase the rate to 80 beats per minute. Okay, so we've got a pace rhythm here at 70. And from now, what I want to do is ensure that we do a full set of vitals. I want to ensure that we're getting brachial or radial pulse, and we see an increase in that pulse strength, and obviously the rate included. I then want to look at the overall stability of my patient. Has their GCS improved slightly? Have we got a decrease in the diaphoresis, decrease in the capillary refill time, and then redo his blood pressure, hoping to see a rise in that also. If we are not seeing a significant rise in the patient's cardiac output, the mechanical cardiac output, then what we want to do is increase the rate to 80. How you going, Clive?
Oh, it hurts.
Yeah, so I'm sorry about that. It is quite uncomfortable. What I'm going to do is I'm going to give you some fentanyl. Do you have any allergies to any medication?
No.
No, is that right, Dolores?
Yeah.
Dolores?
Yeah.
You alright?
Yeah, sorry.
Okay, sorry, it didn't sound very well. With this patient, what I'm going to do, give you, Clive, we'll give you 50 micrograms of fentanyl, okay? Just pushing that now, nice and slow.
Okay.
Just make you feel a little bit better, okay?
Oh.
How you going?
Yeah.
Yeah?
Yeah.
Okay, we'll stop that there. That's good. That's 50 micrograms.
Yeah. Good stuff, that.
Yeah.
Yeah.
How's your pain like at the moment?
Yeah, it's good.
Good. So my next option, apart from the fentanyl, which seems to have had a good effect on him, would be low-dose ketamine, sort of between 20 and 30 milligrams. Clive is still a status 1 patient. We've just redone our vital signs. We will continue to monitor him, scoop, load and treat en route on our way to a hospital. Early advisory, obviously at R40 towards that with the hospital, and continue to monitor him with regular vital signs and pain relief management en route.
Stunning.